So this presentation will consist of shoulder joint complex foundations for evaluation, differential diagnosis, and prognosis. So the objectives and student outcomes: students will learn cognitive domain foundations for evaluation, differential diagnosis, and prognosis of the shoulder joint complex, and how those foundations develop through performance and application, which is the psychomotor domain, that increases from basic recall to complex evaluation and creation. So one of the first things we need to know is our anatomy. So we need to be well versed and knowledgeable about our anatomy and our articulations that make up joint complexes. So since we're talking about the joint complex, we need to know that the shoulder joint complex. So since we're talking about the shoulder joint complex, we need to know that the shoulder joint complex consists of 4 different articulations. So we got the glenohumeral joint, which consists of articulation of the humeral head and the glenoid cavity. We got the acromioclavicular joint, which consists of the acromion and the clavicular articulation, and that's the lateral end of the clavicular articulating with the acromion of the scapula. And we have the sternoclavicular joint, where the medial end of the clavicle is articulated with the sternum, the manubrium of the sternum. And then we have the scapular-thoracic articulation, where we have the scapula articulating with the rib cage. So we need to know these because all of these joint complexes play a role with overall shoulder joint range of motion. If a person is limited in active range of motion at the shoulder joint complex, it could be due to a limitation of any one of these complexes. So now we have to know how to assess each joint complex. We have to know how to assess the component motions of these complexes, which we will learn in this course in lab. Then we have to know the GH joint articulations and characteristics. So we know that the convex humeral head moves on the concave glenoid fossa of the scapula with open chain movements. What do I mean by open chain movements? So when our upper extremity is free, moving in space. So that is considered open chain. So we're gonna learn the orthokinematics according to open chain movements. So just know that with closed chain, the orthokinematics change, okay? So, but we're gonna approach it from the open chain to start with. The GH joint, glenohumeral joint, is considered a ball and socket synovial joint with 3 degrees of freedom, okay? So make sure that you know this foundational content. Arthrology of the shoulder joint, you got your osteokinematic motions. What does osteokinematic mean? So the movement of the bone, the movement of the osseous structures, the direction of movement for those osseous structures. So at the shoulder GH joint, we have flexion, extension, abduction. And when we talk about abduction, this one's more so referring to coronal abduction. Medial/internal rotation, you can see either or as terminology, and lateral external rotation. The capsular pattern for the GH joint is pain at the extremes of the range of motion or range of movement. And here's a visual of our osteokinematic motion. So we got flexion and extension occurring in the sagittal plane. This is just foundational content, but you could see a question on this content on the National Physical Therapy exam. You have frontal plane motion being coronal abduction, and we have transverse plane internal and external rotation of the GH joint. Now, can internal rotation of the GH joint occur in the sagittal plane? We have some yes, and we have some no. Okay, who has Norkin and White? Go to Norkin and White, go to shoulder external rotation, internal rotation, and see what plane that external internal rotation is assessed in. In Norkin and White, external internal rotation is assessed in the frontal plane. So that means you can perform internal external rotation in the frontal plane. You can actually exercise someone with internal external rotation in the frontal plane. To achieve full external rotation in the frontal plane requires recruitment of other muscles as well. It's very fascinating. One of those major muscles being middle trapezius. Okay, all right. So now, if a person can't get full external rotation in the frontal plane, not only do you have to assess the external rotators, you also have to look at the middle trapezius muscle as well, because it plays a role with the person achieving full external rotation in the frontal plane. All right.
So is that in the sagittal plane, Dr. Carter?
I mean sagittal plane. Sagittal plane. Sorry, sagittal plane. Will achieve in the sagittal plane. Yeah. So it's assessed. That movement can be performed external, internal rotation of the shoulder joint. For internal and external rotation of the GH joint, it can also be performed in the sagittal plane. And to achieve full external rotation, range of motion in the sagittal plane, it also requires recruitment of the middle trapezius muscle. Again, we got the loose pack position and the closed pack position of the GH joint. Loose pack position being about 55 degrees of abduction and 30 degrees of horizontal adduction. And then for the closed pack position, the person's typically in abduction and external rotation. Some texts you will see full abduction with full external rotation in some textbooks. Now, to achieve the loose pack position of the GH joint, again, to help maintain that when we're assessing component range of motion, or component motion, I would say, when we're assessing component motion, we're gonna put the person in about 55 degrees of abduction, 30 degrees of horizontal adduction, but we're gonna place a towel rope under the arm to help maintain that. That way you can now utilize both of your hands without trying to maintain that person in a loose pack position. So come back up for me, Tia. So again, I will have the patient here. Again, about 55 degrees of abduction. Come here, place the towel roll. Again, your towel roll will be built up enough so that this person can maintain his position. And then now I can just let the hand rest right there. And then that will, when I build up the towel roll, that will maintain the GH joint in a loose pack position. Now I can assess my different component motion, okay? I can assess my posterior glide, I can assess my anterior glide of the GH joint, I can assess the inferior glide, and also I can assess the inferior glide of the clavicle on the sternum. I can assess my clavicle movements on the acromion with all my superior posterior, and also anterior inferior component motion, which y'all will learn as well. Picking back up where we left off. We left off with the arthrology of the shoulder being a humeral joint, and we were talking about the loose pack position and the closed pack position. Who can tell me the significance of knowing the loose pack position? Why do we need to know the loose pack position? Seth said it, make sure that you remember that. Understanding and knowing the loose pack position and placing the person or the joint in a loose pack position is essential for assessing accessory motions. Your accessory motions are your component motions and joint play motions. So you need to have your patient in a loose pack position. In the visual that's showing the loose pack position, the therapist has the person in about 55 degrees of abduction with some horizontal adduction, probably like adduction in the neutral position. And the closed pack position visual gives you a visual for the closed pack position. You will have some text that will say abduction, full external rotation, which is what you would see, corona abduction, full external rotation here. You have some text that may say full corona abduction and full external rotation for the closed pack position. But just know that the person is going to be in some form of corona abduction and external rotation for your closed pack position. at the GH joint. All right, so now we're gonna be talking about the sternoclavicular joint. So the arthrology showed the sternoclavicular joint. So the sternoclavicular joint characteristics, you got the medial end of the clavicle articulating with the manubrium of the sternum. It's a saddle-shaped synovial joint. So what does that mean? It's a saddle-shaped synovial joint. It means that it functions like the carpal metacarpal joint of the thumb. Okay, and we're gonna go with that. So what that means is with shoulder corona abduction of the sternoclavicular joint, you're gonna get your glide, the slide and glide is gonna occur in the opposite direction of the movement. Okay, that's with corona abduction. However, with horizontal abduction, your glide or slide is gonna occur in the same direction as the movement because it is a saddle-shaped synovial joint. But we'll go more into detail about with that when we get into the orthokinematics of the sternoclavicular joint. Again, this is another joint that has 3 degrees of freedom. You have a fibrocartilaginous disc that enhances stability. It absorbs a shock. It is a shock absorber, and it functions as a fulcrum, axis for clavicular rotation, which is also required to achieve full range of motion at the shoulder joint complex. And your osteokinematic motions at the sternoclavicular joint, again, elevation, depression, protraction, retraction, and rotation. And the capsular patterns are pains at the extremes of the range of movement, which may be worded different in your Dutton textbook, and this is from Score Builders here. So when we talk about your osteokinematic motions, when we say protraction, what does protraction mean? So protraction is moving away from midline. So if protraction is moving away from the midline, what is retraction? So moving towards midline, okay? So make sure you understand the terminology. So when we say depression, what does that movement consist of? So an inferior or caudal movement. And when we say elevation, what does that movement consist of? A superior cephalic movement, okay? So movement towards the head. Then you have your depression, which is an inferior caudal movement towards the tail, okay? So again, our osteokinematic motions, you can see posterior rotation, you see retraction, depression, elevation, and also protraction. If you look at protraction, you look at those arrows, it looks like the arrows can be pointing posterior, but what it's saying that is that clavicle, that lateral end of the clavicle is moving more towards the midline, and the lateral end of the clavicle with protraction is moving more so away from the midline. So that's what those blue arrows are indicating. That's what they're indicative of. And the gray arrows with elevation and depression, those are self-explanatory. So loose pack position for the sternoclavicular joint, the arm resting by the side, and the closed pack position is maximum shoulder elevation. And again, the loose pack position in lab, we're gonna maintain the same loose pack position that we maintain for the glenohumeral joint when it comes to assessing the component motions and accessory motions. But as long as the arm is at maximum shoulder elevation, we will be in a safe zone for assessing the loose pack position of the sternoclavicular joint. We do also proper pillow or a towel roll under the arm for helping to maintain a loose pack position for the sternoclavicular joint as well. Here's some visuals for loose pack position, arm resting at the side. However, we will add a towel roll to that for the loose pack position to help maintain that loose pack position. And the closed pack position is full elevation of the shoulder joint complex for the closed pack position for the sternoclavicular joint. Now we're gonna talk about the acromioclavicular joint. So the acromioclavicular joint consists of the articulation of the acromion process of the scapula and the lateral end of the clavicle. It's considered a plain synovial joint, also with 3 degrees of freedom. Now it functions to maintain a relationship between the scapula and the clavicle during glenohumeral joint range of motion. So that is significant. And then the osteokinematic motions at the acromioclavicular joint: anterior tilting, posterior tilting, upper rotation, downward rotation, protraction, and retraction. And these are actually the movements that the scapula makes when referred to tilting. Who knows the reference point when we're talking about tilting of the scapula? Who knows the reference point that we're referencing when we're talking about anterior tilting and posterior tilting? It's the inferior angle. So the inferior angle of the scapula is either going to tilt anteriorly or forward, or it's going to tilt posterior. And we're using that as the reference when we're talking about anterior tilting and posterior tilting. Downward rotation, the inferior angle is going to move how? It's going to move away from the midline. So it's going to move away from the midline and superior. With downward rotation, the inferior angle is going to move toward the midline with downward rotation. In protraction, the scapula and acromion is going to move away from the midline, and then with retraction, scapula is moving towards the midline. The acromion, all right? And here are the visuals for the movements, and you can look at these and see it's showing you what the clavicle is doing in conjunction with the acromion and scapula as well. So the acromion and the scapula is moving as an entire osseous structure. So if you look at your diagram, and as you see with elevation, the acromion is moving superior and the clavicle is moving superior too. So therefore the AC joint is considered to be elevating, moving superior in a cephalic manner. It would be the opposite for downward rotation, okay? So downward rotation, remember I told you that the inferior angle of the scapula is going to be moving more towards midline. With upward rotation, again, the inferior angle moving away from the body. So moving away from the midline and also combined with elevation. That's upper rotation. So we can actually mobilize the scapula into upper rotation, downward rotation. We can manually mobilize the scapula into elevation, and we can also manually mobilize the scapula into depression. Someone already pointed out with posterior tilting and anterior tilting, referring to the inferior angle of the scapula, and you can see this in the visual in this slide. Also, you see a visual of protraction and also internal rotation. So protraction again, moving away from the midline, and we will get some internal rotation of the GH joint complex with that, also acromioclavicular joint. So acromioclavicular joint, loose pack position, again, arm resting by the side, and the closed pack position is the arm abducted to 90 degrees. So here's a picture of loose pack position and a therapist mobilizing the acromioclavicular joint. So mobilizing the clavicle, the lateral end of the clavicle on the acromion. And then this is a visual of the closed pack position for the acromioclavicular joint. That's when it's at the most congruent position. So the closed pack position is when the joint is at its most congruent position. Now we're talking about the orthology of the shoulder scapulothoracic articulation. So what do we have? We have the body of the scapula, articulating with muscles covering the posterior chest wall. The motions consist of the scapula sliding on the thorax. This is typically referred to as a false anatomical joint, which lacks synovial characteristics because you don't have an intimate joint relationship when we're talking about osseous structures articulating with each other. So with the scapulothoracic articulation, typically in most of the other joints that we see, you have osseous structures articulating with each other. Whereas with the scapulothoracic articulation, you have an osseous structure moving on the posterior chest wall, which is moving on muscles of the posterior chest wall. Shoulder joint muscle action, we need to know that flexion, all of the muscles that contribute to flexion of the shoulder joint are anterior deltoid, coracobrachialis, the pectoralis major, clavicular head, and the biceps brachii. And with extension, the latissimus dorsi extender, posterior deltoid, teres major, and triceps brachii long head. So this goes back to understanding how to isolate and knowing which muscles to isolate as well. Remember I talked about isolating the posterior deltoid with manual muscle testing, muscle selective tension testing. And so if we don't isolate it, you see all the other muscles that are being tested as well, such as the latissimus dorsi, teres major, and triceps brachii long head. So if I just have the person go into extension and I manual muscle test the person in extension with the arm by the side, then I'm not isolating the posterior deltoid. So that understanding the muscle action plays a role with even your performance with manual muscle testing and muscle selective tension testing. Also, again, I know that if a person is not able to achieve full flexion and they have an abnormal firm infield, I can go as far as say, okay, this person has an abnormal firm muscular infield with shoulder flexion. So what am I saying? I'm saying that any of these muscles that actually extend the shoulder could be muscles that could be taut in limiting shoulder flexion, yielding a abnormal firm muscular infield. Does that make sense? Okay, so understanding joint muscle action helps you clinically with determining infields. And then here's just a diagram of shoulder joint muscle action where you have your muscles moving the joint into a certain direction. So in this case, you would have the coracobrachialis and the anterior deltoid and the long head of the biceps since it crosses over the joint, contributing to shoulder flexion. And then with shoulder extension or shoulder hyperextension, it's showing you the posterior deltoid, long head of the triceps brachii, lateral head of the triceps brachii, latissimus dorsi, and teres major as muscles contributing to shoulder extension. Shoulder joint muscle action for abduction and adduction. So for coronal abduction, we know that's the middle deltoid and supraspinatus muscle. And for adduction, we know there's a pectoralis major, latissimus dorsi, and teres major. And so when we say adduction for pectoralis major, what type of adduction are we talking about? We're talking about horizontal, and then also contributing to coronal adduction as well. Okay. Latissimus dorsi muscle is also an adductor of the glenohumeral joint. So if someone lacks with coronal abduction, it can also be a limiting muscle to coronal abduction since it's an adductor. And then of course, teres major being an adductor as well. And these are visuals for those muscles. So go back and look at your visuals and look at the muscle actions, get a visual picture of these. Visualization can help you on a written exam. It can help you on a lab practical. So being able to visualize what that muscle does. We talked about the middle deltoid and supraspinatus being coronal abductors. And middle deltoid, anterior deltoid working together to achieve coronal abduction. And so basically for coronal abduction, all of the deltoid muscles work together to achieve coronal abduction. And when we see deltoid, supraspinatus, and subscapularis, infraspinatus, teres minor, all acting together with abduction. And then for with adduction and extension, You see the clavicular head and sternocostal head of the pectoralis major adducting the GH joint. And here's more shoulder joint muscle actions. So horizontal abduction, okay, posterior deltoid, infraspinatus muscle, and teres minor. And with horizontal adduction, anterior deltoid, and pectoralis major playing a role in those. And here are some visuals for those. We see infraspinatus in the spinal part of the deltoid, contributing to transverse shoulder abduction. And then we see transverse shoulder adduction. When we say transverse, we're talking about horizontal. So I'll be also talking about interchangeable terminology as well. So pick up on the interchangeable terminology because you can see either or on your exam. So it's good to know and understand interchangeable terminology. So you have the clavicular part of the deltoid, pectoralis major, and coracobrachialis playing a role in shoulder adduction. And then our rotators. So we have our external rotators and our medial rotators. Teres minor, infraspinatus, posterior deltoid being external rotators, and internal rotators being subscapularis, teres major, pectoralis major, latissimus dorsi, and anterior deltoid. So we know that the rotator cuff muscles have a specific function in rotating the GH joint. What do they do for the humeral head? Okay, so Seth says compress it in the joint socket. Tavian gave me a question. Tavian said, don't they pull it inferior? So Tavian said that the rotator cuff muscles pull the humeral head inferior. Yes. So they provide an inferior pull to the humeral head. So why is that important? Why do they need to provide that inferior pull to the humeral head? So just think about the anatomy. So if the rotator cuff do not provide the inferior pull to the humeral head, what do you think will happen? Impingement. So the humeral head is gonna actually move superiorly, and then now you're gonna get the tendon of the rotator cuff muscle on supraspinatus. You're gonna have some impingement going on. You can even have some impingement of the bursa as well. You can have some impingement of the long head of the biceps brachii could get involved. And so now you got some issues that can occur due to the lack of rotator cuff muscle efficiency. What kind of stabilizers would the rotator cuff muscle be considered? Would they be static stabilizers or dynamic stabilizers?
Dynamic.
Dynamic. I'm just coming from content in the book, you all. So actually muscles are dynamic stabilizers. So muscles are considered dynamic stabilizers. What would be inert or non-contractile stabilizers? Ligaments and what else? Tendon, musculotendinous unit, that's gonna be dynamic.
Okay, that's what I was thinking, because, yeah.
So ligaments and also the joint capsule, okay? So the joint capsule is an inert structure that's gonna be a static stabilizer, okay? So you need to know that muscles are dynamic stabilizers, okay? They're contractile structures that are dynamic stabilizers. Inert structures are non-contractile structures that are considered static stabilizers, okay? So that would be like your ligaments and your joint capsules. So this is content that's not on here, but this is content that is in your book. Another thing too, understanding the muscle action is very important. So if you look at your rotators, I'm spending a bit of time on the rotator muscles because they are significant at the shoulder joint complex. So if you look at the subscapularis muscle, right? The subscapularis muscle is a what? It's an internal rotator. But say if that subscapularis muscle is very taut, say that if it's very taut, very hyperactive. If the subscapularis muscle is taut and hyperactive, which range of motion would the person likely have the greatest limitation with? external rotation, because the subscapularis muscle cannot lengthen. So if the person has a tight or hyperactive or taut subscapularis muscle, that could actually mimic what? It can mimic the capsular pattern, right? You can end up seeing a patient that presents with what we call a capsular pattern, where external rotation is greater limited than abduction, then followed by internal rotation. So if we see someone, we need to, and they present with a capsular pattern, we need to check the subscapularis muscle. We need to assess it. We need to palpate it. All right, we need to know how to do that, because it could present as if the person has frozen shoulder. Remember with adhesive capsulitis, what's the capsular pattern?
External rotation, abduction, and internal rotation.
There you go. So this is how a condition of the subscapularis can mimic frozen shoulder. All right, because it could, the person could present as if they have a capsular pattern. So capsular patterns are more so specific to the actual joint, the intimate relationship between the joint, okay? So here's another visual of shoulder joint muscle action. So you all can go through these visuals and look at the visuals to make sure that you have muscle actions down. Muscle actions can change your grade. Understanding the muscle action can change your grade to whole letter grade, because you gotta know the muscle action for every last practical in your orthopedic courses. You gotta have a strong command of muscle actions for every lab practical in introduction to orthopedics and also clinical orthopedics. So we're looking at the spinal part of the deltoid in one of the visuals, and the infraspinatus and teres minor, laterally rotating and externally rotating the arm. We're looking at the internal rotation being subscapularis and teres major, also latissimus dorsi. So if latissimus dorsi is taut, it can also limit external rotation, right? So now we know when our patient present with a limitation in range of motion, we need to know that we need to be checking the antagonistic muscles to that movement. So that's the reason why understanding the muscle action and doing the muscle action is very essential. It's very important. So we need to screen those muscles, check those muscles that are antagonistic to the movements. All right, and that entails understanding and knowing muscle action. Now we got the scapular muscle action. So these are muscles that act on the scapula: upper trapezius, levator scapulae muscle. And these muscles also act on the cervical spine as well. With depression, you have latissimus dorsi, pectoralis major, pectoralis minor, and the lower trapezius muscle. All muscles that act at the scapula, okay? So upper trapezius, levator scapular muscle, they elevate the scapula, and the latissimus dorsi, pectoralis major, pectoralis minor, and lower trapezius muscle, they depress the scapula. And here's some visuals for those. So you see the levator scapular muscle, you can see the upper trapezius muscle, and how they both act to elevate the scapula. And then you can go on the other side and look at the visuals, and you can see the latissimus dorsi muscle, you see the lower trapezius muscle, and also the pectoralis minor, and how they can depress the scapula. And so if you have a tight pectoralis minor muscle, that could be instrumental in limiting overhead mobility because it depresses the scapula. So if the scapula is depressed, the person is going to have limitations with overhead mobility. For protraction, the serratus anterior and pectoralis minor are going to contract concentrically to protract the scapula. And for retraction, the trapezius, middle trapezius, and rhomboid are going to retract the scapula. So here we go. Again, I like visuals. Visuals help contribute to memory and recall. So serratus anterior muscles being protractors, of the shoulder joint complex, and protractor of the scapula. Serratus anterior muscle. Are those static or dynamic stabilizers? Dynamic stabilizers. So if you have someone who has poor control of the scapula, and they can't control the movement of that scapula, and their scapula is either tilting or winging, you have to strengthen those dynamic stabilizers of the scapula. It could be that they are weak, okay? So now you need to know, okay, what can I do to strengthen these dynamic stabilizers of the scapula? All right, what do I need to do to get the scapula to moving better? Because we know the scapula has to be able to move in order to get full GH joint movement. We have the middle trapezius, rhomboids, and lower trapezius again as your retractors of the scapula. And so that's moving midline, looking at the arrow, moving the scapula towards midline. Upper rotation, the trapezius, upper and lower trapezius, serratus anterior. And for downward rotation, your muscle action is going to be concentrically with the rhomboids, levator scapula, and also pectoralis minor. And here's a visual of those. So upper rotators of the scapula, we're looking at the upper part of the trapezius, serratus anterior, and also lower part of trapezius. And with downward rotation of the scapula, we're looking at the rhomboids, levator scapula, and pectoralis minor acting together. So this gives you a good visual of how these muscles are the forces that the muscles are putting on the scapula and how the scapula is moving with those forces. Oh, here goes the fun part. So now we're getting into the GH joint osteokinematics and arthrokinematic motion. So with the glenohumeral joint, we have, this is open chain. So we're talking about open chain, right? With an open chain position, we have the humeral head, which is convex, moving on the concave glenoid fossa. So your OK, AK are gonna occur in an opposite direction, all right? So your osteokinematic motion and your arthrokinematic motion are gonna occur in an opposite direction. Well, what does that mean, Dr. Carter? No, we don't have Charlie here. So if I get a superior roll and swing of the humerus, right? So if I go coronal abduction, or even if I go sagittal plane flexion, I'm getting a superior roll and superior swing. So roll and swing occur in the same direction, you all. So you want to notate that roll and swing is always occurring in the same direction. All right. And when we're talking about convex moving on concave, the glide or slide, notice I say glide or slide and use interchangeably, is occurring in the opposite direction. So with my superior roll and swing of the humerus, I get an inferior glide or slide of the humeral head on the glenoid fossa. That was a coronal abduction, and also with flexion. Now, in most textbooks with flexion, this is what you see. You see a pure spin in most textbooks. So most textbooks are gonna say with the flexion is a pure spin. But with flexion, you do get some component motion with a combination of inferior glide and posterior glide. So now we're talking about a posterior roll and swing of the humerus. So when I'm gonna talk about extension here. So if I do extension, I get a posterior swing and roll, correct? And now what's gonna happen with my glide and slide? It's gonna occur anteriorly, all right? If I get a anterior roll and swing of the humerus, so say, all right, I'm in the sagittal plane. So this sagittal, I'm going sagittal plane internal rotation. So sagittal plane internal rotation, right? Sagittal plane external rotation. So sagittal plane internal rotation, which way is the humerus swinging and rolling? Anteriorly. Notate this. And so therefore I get a posterior glide or slide. Again, you see the picture with corona abduction. You see the superior swing and roll of the humerus, where you see the slide or glide in the opposite direction, which is inferior. You need to have a strong command of this. This is entry-level content. So if you are struggling with osteokinematics and orthokinematics, make sure that you get with peers. Make sure you take me inside, myself or Dr. McClure, and like, okay, explain this. I'm not grasping this. I need an understanding of this, so that you can get this down. The understanding this now is the best time to learn it. All right, you gotta learn this now. You don't want to be learning this when it gets towards close to the time of taking the National Physical Therapy exam. A lot of things you want to get a strong command of, like right now, yesterday, really. This was supposed to be commanded yesterday, right? All right. And so with external rotation, now external rotation, whether I'm in a transverse plane or whether I'm in a sagittal plane, it doesn't matter with the rotation. With external rotation, I'm gonna get a posterior swing and roll of the humerus with an anterior glide. Okay? Now, these orthokinematic motions are intimate motions that occur within the joint articulations, with the joints that are articulated together. So these are motions that have to occur in order for a person to achieve full range of motion as well. So if the humeral head is not gliding anterior like it should, or the anterior joint capsule is taut and restricting the humeral head from gliding anterior like it should, then that person could present with a decreased external rotation, active range of motion. So now you need to know how to assess component motion, all right? Now the clavicle movement on the acromion. So now we're talking about the AC joint. So with the AC joint, you have the convex clavicle moving on the concave acromion. So what does that mean? When we have convex moving on concave, we know the convex concave rule, right? So we know the osteokinematic and orthokinematic motions are going to occur in what directions? Opposite directions. So if we have an upward superior roll and swing of the acromion, right, of the clavicle on the acromion, an upward superior roll and swing of the clavicle on the acromion, then we're going to have an inferior anterior glide or slide of the clavicle. All right. So we got an upper superior roll that's going to result in an inferior anterior glide. And we'll go through this in lab. Now, if we have a downward and inferior roll and swing, and that's going to result in a superior posterior glide of the clavicle on the acromion. So here's a diagram showing us the axis for elevation, depression movements, and then an axis for axial rotation movements, and then we get the axis for protraction and retraction movements. So you just go in and look at those for a visual effect. With elevation and depression, you have convex clavicle moving on the concave sternum. So the medial end of the clavicle moving on the manubrium of the sternum. So therefore, your OK and AK are going to be in the opposite direction. So with elevation, you're going to have an inferior glide of the clavicle on the sternum. So this would have to occur with shoulder elevation. So with shoulder elevation, an inferior glide of the clavicle on the sternum has to occur. And you're going to be shown how to assess the inferior glide of the clavicle on the sternum. With depression, a superior glide of the clavicle on the sternum has to occur. This is the visual for the elevation and depression or orthokinematic motion. So you can see right here, elevation of the clavicle on the sternum, where you get a superior swing and roll and an inferior glide or slide of the medial head of the clavicle on the sternum, the manubrium of the sternum. And then with depression, you can see an inferior roll, inferior swing with a superior slide or glide. This is where it changes, because now we have a convex sternum. The sternum now becomes convex, and the concave clavicle is moving on the convexity of the sternum. So again, I'm gonna repeat that. With retraction, with protraction and retraction of the sternoclavicular joint, you have the concave portion of the clavicle moving on the convexity of the sternum. When you have concave moving on convex, what do you get? You get the osteokinematic and orthokinematic motion occurring in the same direction. So for example, with protraction, all right, so protraction, moving the scapula away from the midline. So if I move the scapula away from the midline, all right, with my sternoclavicular joint, what's happening, I do shoulder joint complex horizontal adduction. So what's gonna happen is I'm gonna have an anterior glide of the clavicle on the sternum, because now my clavicle is moving anteriorly because I'm moving away from the midline. So you gotta picture this. My clavicle, now that I'm doing horizontal adduction, my clavicle is moving away from the midline, is moving anteriorly. Okay, my clavicle is translating anteriorly. So now I'm gonna get an anterior glide of the clavicle on the sternum, because now the concave portion of the clavicle is moving on the convexity of the sternum. It's a saddle joint. It changes like the CMC joint, okay? And with retraction, with horizontal abduction, now I'm gonna get a posterior glide of the clavicle on the sternum. So if I wanna improve, so if a person is limited with the posterior glide of the clavicle on the sternum, guess what? I can come mobilize that. I can mobilize the medial end of the clavicle posteriorly on the sternum to help improve with horizontal abduction. So, again, with retraction, so retraction moving towards midline with horizontal abduction, roll and slide are gonna occur in the same direction, moving posteriorly, okay? And here are our shoulder joint complex average adult range of motion. So this is what you have to be able to verbalize during your practical, when you're doing your goniometric main ranges of motion, when you're quantifying active range of motion. You know, at the end, one of your bullets is to be able to verbalize the normal range of motion for that joint. So make sure that you go back and study these to know the normal range of motion for the joint. And it's good because when I'm working with my patients, I take the range of motion. I say, oh man, you got 0 to 40 degrees of external rotation. Then I'm able to let the patient know, well, normal is about 0 to 90 degrees, okay? Then the patient like, oh, I got some work to do. And I'm like, that's a problem. I put an asterisk by it. I say, this is a problem that we're gonna work on, all right? Show the special test outline. So you need to know, first of all, what are these tests for? So you need to know that you had an apprehensive test for anterior shoulder dislocation, and there's an apprehension test for posterior shoulder dislocation. And then you have the SOFA sign for either GH joint or AC joint dislocation. Bicep tendon pathology, the Ludington's test, Speed's test, and Jurgensen's test are your go-tos for bicep tendon pathology. These are special tests that you need to come in now. So I know you haven't had special tests before, that's why I say now. All the other stuff is like yesterday. But this is like now when we start going through it, okay? Don't get behind. Rotator cuff pathology. You got your drop arm test, infraspinatus test, lateral rotation lag sign, lift off sign, and supraspinatus test. Now, within the special tests themselves, you can get a stronger clinical impression. So a positive drop arm test can lead you to doing the infraspinatus test and supraspinatus test. Also lift off sign, okay? And to be more specific, rotator cuff impingement, Hawkins-Kennedy impingement test, near impingement test, and supine impingement test. Another thing you need to know about special tests. Special tests are not all inclusive, but they help with developing a strong clinical impression. So when you get a patient, when they come through the door, do you only do special tests with them? No. So you go through all of your examination process, you know, the pertinent components of your examination process, which we're gonna go through in a lab. And I posted a presentation for that as well in module 1. All right, so you go through those components, different things that you're gonna do with your examination, and you include special tests, and then you have a stronger clinical impression of what the dysfunction could be. And then thoracic outlet syndrome, you have your Addison's maneuver, Allen's test, costoclavicular syndrome test, Rule's test, and Wright test, which is considered a hyperabduction test. Of these tests for thoracic outlet syndrome, for some reason, Rule's has been considered like the gold test or the gold standard test for thoracic outlet syndrome. You may want to notate that. And other miscellaneous tests, your acromioclavicular test, a crossover test for AC joint pathology, AC joint arthritis, active compression test, which is O'Brien test, glenoid labrum test, or glenoid labrum tear test, and jerk test. And here are my references in AMA. What questions do you have?